I love giving this lecture. I like to start by clarifying my expertise, and actually what I'm not an expert in. I'm not an expert in diagnosing autism. I'm not an expert in knowing the treatments and modalities that we should use to try and have someone with autism succeed. I'm a primary care physician, the first person you see when your child comes in for multiple reasons. But I've been lucky enough to be brought into the autism world, and my goal tonight is to take physician worlds and parent worlds and bring them together so that we can make our visits quality visits, good visits that make a difference. So one thing I'm going to ask everybody to do tonight is I want parents to especially pay attention to what I say about the doctors, and I want the doctors to pay special attention to what I say about the parents so that we can come together, because this won't work unless we're working together with this. We'll go in this order just to know what's coming. First, we're going to talk about where this lecture came from, its birth basically. We're going to review what autism is, characteristics of patients on the spectrum, so that, again, everybody knows what we're talking about. We're going to talk about the challenges for providers. We're going to talk about the challenges for parents. And then we're going to talk about solutions, suggestions, ways we think we can improve on many facets of these visits. So the first part of where this visit came from is Michael. Michael is there on the screen with his mother, Beth, and he has autism. I have been lucky enough to be involved with this family as a dear friend for the past 10 years, and I needed to be involved with this family because they've completed my education. They've taught me what I needed to learn in medical school, in residency, and probably even in my first several years of practice that I wasn't formally taught or exposed to. And this lecture came from an event that Beth and I had together. Michael, at about this age, had a seizure while he was at school, and Beth got a call that he was being brought to the emergency room. So she called me as a friend, not a physician. She was frantic, as any of us would be, and asked me if I could meet her in the emergency room. So I did. We both arrived at about the same time. And when I walked in there, I saw a group of very, very well-intentioned healthcare providers at every level trying to care for him. But it was a disaster. And it was a disaster simply because he was being approached the way we were trained to approach him. Michael's autism world was left at the school. When he went through the emergency room doors, he came into our world, and our approach did not work with him. So then I'm shortly thereafter talking to Jalynn about this. And Jalynn, Madison House in general, has a tendency to problem solve or take lemons and turn them into lemonade. So she challenged me and said, well, what can we do about it? Is this happening all over? How can we make it better? We have a conference coming up. Maybe you should design a lecture that you can give at the same time to doctors and parents that everybody can understand and have it ready. I said, okay, we'll do it. So I went to these worlds to look at what was going on. I went to our literature to see if anyone's writing about this. Is this something that's happening? Is it something we're aware of as physicians? Are parents being talked to? Is someone studying it? I looked at medical schools. I looked at their curricula. What are we doing? Have things changed, perhaps, since I was there? I spoke with parents, and I spoke with fellow doctors. So let's stop and talk about autism before we talk about what I discovered. That snowflake is there to remind me, to remind you, that I'm about to give you a whole bunch of characteristics of someone on the spectrum, but they're individuals. They could have one of these things in a very severe degree and one hardly at all. So there's no prototype for you to memorize. You might be at a cocktail party where you go, I think that person's on the spectrum. You might realize it afterwards because there's no cookie cutter description of someone on the spectrum, but we'll go through some of the things you may see. First, there's impairment in communication and social interactions. So someone on the spectrum can be very verbal. They might talk to you a lot. They might talk to you a lot about something you actually have absolutely no interest in, but they have a huge interest in over and over and over again. They could also be nonverbal. They might not have words for you. They might communicate in different ways. Maybe they sign, maybe they use picture exchange, but they might not be able to talk to you at all. When they do talk, we've actually discovered very recently there's a lag time in the information going in and coming out when they are talking to you. So even if they are verbal, it might not be the ebb and flow we're used to. Socially, when they talk, many times it's very painful to initiate conversation. We just all stood up there and chit-chatted with one another. That's torture for many on the spectrum. That little beginnings of conversations. They probably look at it as useless, I don't know, but it's hard for them to do that. Our responding, our back and forth. So when we were all upstairs talking, there's a natural ebb and flow. We know to talk, I know to wait, I know to listen to your response, I need to look like I'm interested. That ebb and flow doesn't usually work with many on the spectrum. They could interrupt you. They are not being rude. They don't get that that is rude. They had a thought to come out, it's going to come out. They're very frank many times. Again, the interests. I have a patient who talks to me about World War II every time he comes in my office. I actually have had to study about World War II to be able to talk to him about it because he knows so much about it. The nonverbal communication behaviors. So when we are talking upstairs, you all could probably get the cue if someone was bored with you, right? Like we know, oh, he's not really interested, they're glazing over, I get it, okay, let me change the conversation. They might not pick up on that. They might not pick up on that you're sad, or that you're interested, or that you're bored, or that you don't feel very good. There's a restrictedness to many on the spectrum's behavior. So I say this a lot to my parents. I say to them, I know change is the enemy in the world of autism. Change can be awful, and it can be minimal change. Think about that for a minute. A lot of us aren't good at change, but it's usually major stuff. This could be, and I'll go back to, I call it the School of Michael. This could be an example of, Beth used to tell me when he was little, if she changed where a painting was hung on the wall, there was a tantrum, a flailing, screaming tantrum. Sameness. There might be a propensity for sameness in interests, like we talked about. There may be repetitive behavior. This could be a motor behavior, rocking, flapping, lining things up over and over again. When Michael was little, he used to carry a straw that he always was wanting to spin around and look at. Sensory issues, a huge point I want physicians to listen to, and parents probably already know this. But many on the spectrum don't feel pain like we do. They might not feel temperatures the same way also. Jolene alluded to the fact that medicines a lot of times in lower doses. There's this whole wiring side, this whole biochemical side that can be different with many on the spectrum. Lights can really bother a lot of them. There's a thought that many can actually hear the buzz, the sound of the fluorescent lighting above their heads. That can be enough to trigger maladaptive behavior or a tantrum. Pain, we talked about a little bit there. The time lapse we talked about. Deep pressure. Some don't like light touch. Light touch to them where you think you might be being gentle. That's what our mode is that we go into as physicians. Let me be gentle with you. That can be upsetting. Deep pressure might feel better. Again, this is going to vary with each individual. 1 out of 68. When I first gave this lecture, it was 1 in 110. I've changed this slide twice. So they're coming through your door, and they're growing up, and they're getting older. And I've grown up with this. I'm a pediatrician. I've gotten my training along the way. But they're coming into your door, and you guys haven't. And we need to pass the torch along to you. This is a visual representation of what I'm talking about. If you took all the people with autism and developmental disabilities and filled states with them, there's the map of our country. Let's go to the doctor's world. We'll talk about physician-identified barriers to providing primary care. First, perceived competence. I was amazed when I found this study. About 2,000 physicians were interviewed. Their perceived competence in dealing with this population was that they would rather you bring to their office someone with chronic, complex medical problems, a problem list of diagnoses this long, than one, the word autism. If they did feel competent, it was because they had family members with autism, or they had a friend whose child had autism, the School of Michael, or they had happened to seek out some CME. That's in our world, continuing medical education. They had gone and read about things on their own. So pause and think about that for a minute. If you're going to have surgery, do you want a surgeon to go, I'm pretty good at heart surgery. I've had a family member who's had it, some friends, and I've read about it quite a bit, and I've watched it a few times, right? That's not our comfort zone. So we're not comfortable with this. Our training and our education. It's creeping into the medical schools bit by bit. There is one undergraduate program in the country that has a course about autism, and that's Yale, and they just released that. In medical school, there are some patient-physician communication courses where it's creeping in, where they're helping teach young doctors how to talk to people, and they're having them interview patients on the spectrum, so it is creeping in there. In residency, it's more just getting exposed, maybe seeking out doing a psychiatric rotation so that you can get some exposure, but a psychiatric rotation isn't helping me know how to examine you. And again, it's getting into our CME. People are recognizing that we want it. It's getting easier for me to find some things to read about. Emergency rooms across the country are creeping up with their own little sort of protocols. I found one in Pennsylvania that created a 50-minute tape for their staff to watch. Fantastic, very, very focused with just how to talk, how to examine, things to do, adjustments to make. So it's growing, but it's probably not growing fast enough to be ready for the adult population coming. We're uncomfortable because we don't know what to tell the families to do. We were talking earlier tonight about a child being diagnosed, and the mother said, and the doctor didn't tell me what to do. And I said, because you didn't know. We don't know. I don't know what resources to tell you to get. I don't understand, autism, right? In the sense that I'm now treating you for something that I really don't have a grasp on what causes it or cures it yet, so that's not my comfort zone. I'm not sure what's out there in the community for you as far as resources go. I'm used to talking to my pediatric patients about safety, the parents about safety issues and what's to come, but are there safety issues for a 25-year-old with autism? Aren't we past the safety talk at this point? I'm not sure what to tell you to do or what's coming up in that world. And anticipatory guidance. I don't know if this is used in the internal medicine world, but in our world, we have such fun with this because anticipatory guidance is, all right, we're done with your 1-year-old checkup, and your child's meeting all the milestones, and here's what's coming next. I'm gonna guide you. I'm gonna tell you what he's gonna be doing by his 15-month checkup. I'm gonna tell you ways to prepare for it or adjust. I don't know what's coming for them. I don't know if things are gonna get better. I don't know if behaviors are going to extinguish. I don't know if tantrums are gonna stop. I don't know if they're gonna talk. So I'm not comfortable because I just feel sort of useless. Family trust and satisfaction. Regardless of any data out there, there's a lot of skepticism concerning vaccines. There's a lot of worry about that. And that's something I don't challenge. I appreciate that. But that leaves you with a level of distrust because we're the ones giving them out. There's also complementary alternative medicine being dabbled in. How couldn't there be? Our neurotypical population, about 50% of people are using complementary alternative medicine. I've read statistics anywhere from 70 to 95% of parents have tried something out of the box. Well, how couldn't they? They don't know what fixes things. But we're uncomfortable with that world because nobody taught me what herbs do when I was in medical school. Our primary care models. It doesn't matter what your diagnosis is. We never have enough time in the day. Our scheduling is rough. There's an art to scheduling, knowing how much time you're going to need with someone. And then no matter how much, and the doctors can relate to what I'm going to say, you put 99215 on a bill, you can ask for more money for the time you spent, but you might not get it. That's just a reality. It's hard to put aside the time you think you need to care for this population. And what I'm hoping to teach you is you don't need as much time as you think. You can get through this. Over to the parents. Access to health care. This is not addressing whether parents can afford health insurance or something like that. It's not the access we're talking about. We're talking about, again, a fantastic study where parents were simply asked, do you feel like when you go to a doctor for a sore throat for your child or a checkup, do you think you're getting the same level of care as everybody else who's in the office that day? And they don't. But that's okay, because we know we're not giving it. We're all actually on the same page. The visit. So let's go back to my favorite saying, change is the enemy in the world of autism. So now we have an office visit. We're breaking a routine. That's huge. You've broken a routine. There might be a fight just to get in the car, get out of the car, get in the elevator, and come upstairs. I'll go back to Beth and Michael. I remember once I helped her take him to a neurologist. It was summertime. We were dripping in sweat by the time we got to the front door of his office. Then you wait. You wait for us in a room with awful designs like this and noise and smells and sounds. And it doesn't even have to be a horrible room like that. It could be a very quiet internal medicine foo-foo office with a coffee maker on the side. It doesn't matter. It's different. Different doesn't do well. Now the doctor comes in and the parent is there and they're supposed to tell you perhaps their child's past medical history because you've never met them before, or they're in an emergency room and they're telling you what medicines they're on. So they're trying to provide that for you, but maybe they have a child who's fighting to get out the door and escape this place. And then the doctor struggles through the visit and then tells you what to do as a parent. Again, I'll go back to my neurology visit, my education outside of medical school. At the end of that visit, I asked Beth if she knew, and she's very smart, what the doctor said. She didn't get what he was saying. She was tending to her child. Parents are confused about advocacy. You're the expert physicians. They're deferring to you. Who are they to stand there and say, hold on, you might want to take your stethoscope and do this and approach him this way, and maybe you want to talk to. They're not sure how much to help and guide you. They know their child. They know their 25-year-old. They know their 30-year-old, but they don't know if they should share that and in what way with what you're about to do. And they're exhausted. Always assume they're exhausted. I picked a picture of a middle-aged man purposefully because his challenges of parenting have not extinguished. And here's what I mean by that. We all go through, those of us that are parents, exhausting stages, bringing the newborn home, the toddler who's constantly moving, the teenagers who are challenging us and we're waiting up for. But they ebb and flow, they go away, we get a break in between. This 60-year-old could have a 25-year-old who doesn't sleep through the night. He's still getting up, he's exhausted, and he's supposed to compute this visit. There's actually studies done about sleep. People are looking at the percentage of sleep disorders of patients on the spectrum. So in my world, about 30% of the time, I'm going to talk to a parent of neurotypical children of my population about they're having trouble with their child sleeping. We talk about this all the time. 50 to 80% of patients on the spectrum do not sleep through the night or have this thing called the sleep latency, where it takes them a long time to fall asleep, or they just simply don't need sleep. Great. So let's bring the worlds together. I'm going to give you some solutions and suggestions. I put a cookbook there because these are just what they say. They are suggestions. There is no cookbook for you. You're not going to walk away as a physician tonight or a parent and go, oh, I've got it. I know exactly what to do when I go to the office. As a matter of fact, last night when we were setting up, I was telling Jalynn, I had an epic fail last week. And I left there and I came home and I told my family about it. I met this patient. I flipped my switch right over. Yep, I know what to do because I give this lecture in my sleep. Everything I tried failed. Everything the mother tried failed. I felt horrible. Well, when she was leaving, she said to me, you know, I talked to him about this visit for 2 weeks. It was a checkup. We talked. He craves information. I talked to him about it. And then all of a sudden I stopped and I said, but you didn't show him the visit for 2 weeks. Do you want to come back when he goes back to school with your camera and photograph everything? The front door, the parking lot, the waiting area. Come in the room, take a picture of the scale, everything. Go home and show him it over and over and over again. Her eyes lit up. She hadn't thought of that. We started our journey. So I realized this lecture is not going to give you the journey. It's just going to start your journey for you. And you're going to learn as you go. Let's start with the visit. Parents, things for you to do. I just talked about tour before. If pictures don't work, tour over and over and over again. Tour when it's noisy, tour when it's empty. I think all of us are very willing to open up. We already do this. In our office, we have prenatal visits. They come to check us out and look at us and walk around the office. We can do this for you. Just ask us. A medical summary. So even in my own practice, right, I'll have memorized issues with many of my patients. I know how to examine them, but I don't work there every day of the week. And my partners are going to walk in the room. And we have an EMR, but the EMR isn't helping me so much with what to do when I get in there. So this is something an older patient could have on their iPhone. This is something a parent of a younger patient could laminate and keep everywhere, in the backpack at school, in their purse, an older patient on the spectrum's wallet. If you can give me this list, I can get through this checkup. And I'll tell you why. I would say about every 2 weeks, I call it the apology approach, where someone in my office comes to me with a stack of papers and says, Dr. Frankel, I'm really sorry, but I meant to give you this chart to review because they're your next patient and they're brand new and here's their past medical history. And I go, oh, okay. And I can actually flip through that. You would be surprised pretty quick and be able to go in the room. If you give me one sheet, with a list of your child's medical problems, or if you're an adult patient, tell me you have hypertension, diabetes, just give me a list. Tell me what medicines you're on. Tell me what you're allergic to. Most importantly, could you throw me a bone here and tell me how to communicate and examine your child? If you feel you have some tips to give me, tell me that I should speak in a certain way. Tell me that I should explain everything before I do it. I would love it. Bring support with you. Your friends and family want to make this better, and they don't know how, and they watch you suffer. If you ask them to just come with you to an appointment, it could make a huge difference. And I think they could serve one of two roles. They could distract a younger child and maybe bring them out to the car while the doctor's explaining something, or they could be your listener, they could be your ears for you. If you're an older patient on the spectrum and you have a friend who gets you, bring them to absorb the information or help talk to the doctor about what to do. But bring that support. It's priceless. Think about routine. I'll say it again. You're going to hate me because you're going to say it in your sleep, but change is the enemy in the world of autism. Think, parents, about your child's routine and when it is best to break it. If we could actually merge that with our routine, and what I mean by our routine is there are only 2 times in the day we're not running behind. Our first appointment and our first after lunch appointment. Other than that, you could be waiting forever. But if you could request that appointment, that might make the waiting time, we've extinguished that part of the visit. And actually, to add to that before I go on, one of my staff members came up with a fantastic idea where they said they would rather wait in the parking lot. I'm just going to call them when you're ready. I said, sure. I have one more who said he would rather be examined in the pickup truck. Okay. It was a beautiful day. We go out there all the time for lice checks anyway because we don't want them in the office. I went out in the truck. I'm portable. I really needed my stethoscope, my Otis. It was fine. I put guide up there because I am setting you free, parents. Guide us. We want it. Do it. Doctors, ask the expert in the room with you. We're all humble. We're used to calling up the endocrinologist and curbsiding them and saying, can you help me with this? I can't figure it out. You have an expert in the room. Ask them. A couple of weeks ago, I had a new patient come to me, a teenager, and before I went in, they said, Dr. Frankel, she has autism, and they heard you know what to do, so they're here. I said, okay. So I walked in, and there was no paper being handed to me. There was a very, very smart dad there. I could tell he was very involved. And I just looked at him, and it took me 2 seconds. I said, before we get started, I've been told your daughter has autism. Can you just tell me how I should communicate with her and any tips you have for me on how to examine her? And he looked at me and said, really? I said, yeah. He said, if you could shine the light in my eyes, then her, listen to my heart, then her. That's it? Yeah, okay. It was beautiful. It was absolutely no problem. If I hadn't stopped, I would have done what I was trained to do. I will talk to you, I will take a history, I will start my personal sort of routine as I go head to toe and I examine you. But it didn't take extra time. I didn't need to code a 99215. I just needed to talk to him for 2 seconds. Your staff, vitals. Do I really need them? Do I really need a temperature? Do I really need to stick something in someone's mouth and in someone's ear? Do I really need a weight? Do I really need a height? I had a patient the other day who was so cooperative, except just for some reason, didn't want his height taken. He was 4. And I heard the screams, and I said to myself, just put him in the room. And I said to his mother, when you go home today, can you just put a pencil mark on your wall, measure it, and call me later, and I'll put it in his growth chart? She said, we do that all the time for fun at home. Great, I don't need it. I'm not going to get one slight chance of listening to his heart if I make him tantrum over a height, and I really don't need at that moment. Do they have to wear a gown? I think this is something done more in the adult world, but do they have to wear a gown? That's huge, to put a gown. It's too much change. EMLA. So EMLA is a cream that numbs you up for blood draws. I think we're used to offering that numbing cream if someone is a hard stick, they're hard to get blood from, or if someone's a little child who's simply fearful. But what about a 24-year-old? Why not offer EMLA to them? Maybe we could not have to restrain someone and teach them that coming to an office equals being restrained. Your language. Funny story I had the other day. I had a patient who my nurse went in, and she came out to me and said, Dr. Frankel, I said to the mother, what kind of eater is he? And we asked that because we're looking for, is he picky, is he a good eater, is he a healthy eater? And he said, I'm an omnivore, of course, right? So that can be confusing for them when you ask questions like that. So I love this quote, always assume they are hearing. People with autism seem to focus on everything and seemingly nothing all at the same time. Always assume they're hearing you. If they're staring off, rocking, and making sounds, they are still hearing you. Assume they are. Figure out whether simple yes, no's work. For a lot on the spectrum, that's going to work. Things like, what brought you here today? Just like my omnivore patient, you're probably going to get a car. So you might want to say, do you hurt? Right? Keep it yes, no. Keep it short. That abstract form of communication might not work. On the flip side, think of my World War II patient. I hated history, but yes, I learned it. So when he comes in, we chat the entire time together, and it gets me through my physical exam. I have another patient who craves explanations, just wants to know. You're listening to my heart? Yes. What's coming next, Dr. Frankel? I'm listening to your lungs. And we do step by step by step. I have another one who's very, very interested in the ear, and there happens to be a picture of it in the room that we're in all the time. So we talk about that ear every single time we come. He wants it. He craves it. This relaxes him. That doesn't take extra time. The time lapse we talked about, jokes. So we try to set people at ease. I think we're not taught this in med school, but it's something we sort of just grow into where if someone's nervous, we joke with you. Yeah, we all laugh. It sets you at ease. It's raining cats and dogs. It might actually really bother someone because you've gone into a different language for them. So flip that switch, turn it off. That's not going to set them at ease. Leave your ego outside the exam room. They're not being disrespectful. Now, that's easier to remember when you have an 18-month-old who's maybe spitting at you and hitting you, but when they're 22 and they're spitting at you and hitting you, right? Sometimes my staff will come to me and say, that kid's a brat that you're about to see because he's 14 and he didn't want anyone to touch him. They would have never said that for an 18-month-old. I pull them aside, explain to them he has autism. Plugging their ears. This can happen. Your voice might be bothering them. Zoning out. They're not ignoring you. They're still hearing you, but they might zone out. And they could speak very frankly. This is the leave the ego behind part. You know, we're used to good relations and feelings, but when someone looks at you and says, your perfume's horrible. It probably is, first of all. But they're going to say it. It's a beautiful thing, actually. I wish we all could do that more often. With sensory considerations, we talked about talking, but touching, just again, do we want to do deep touch? Hey, we could capitalize on that, right? If we're worried about an appendicitis, they're going to let us do a really good abdominal exam. Maybe they're going to like the pressure. Maybe we can really palpate what's going on in their arm and feel what's going on. Restraining them, please. I have never done it. If there's a life and death situation where you have to, I get it. And I think every parent in this room would get it. But there have been times when people have been restraining children at a well check to look in their ears. I had a patient who didn't want me to look in his ears. And I said to the mother, do you want me to look in his ears? I don't have to look at his ears. Are you worried about his ears? Does he have a history of ear infection? She said, no. I said, then let's not do it. But that's what you guys do. I said, we don't have to. It's fine. They don't know that we have these options, actually. We don't have to do the pattern we're used to doing. Echolalia, rocking, back and forth, maybe escape behavior, running out of room. A change in behavior might be the absolute only indication that something's wrong. So if a parent comes to me and says, he's tantruming a lot, my first question back is, does he always tantrum? No, that's been gone for years. He tantrums when he's, and then they fill in the blank. So do a check-in with that behavior. Ask them, does he rock? Does it make him feel good? Held objects. Any comfort object that they have, please let them have it. If they're going for surgery, let them have that till they are wheeled away and in the operating room. Michael's straw. I often think back to when he had that straw. I bet if you pulled that out of his hand, it would be the equivalent of a pin out of a grenade. Leave it alone. Let them have it. Diagnostic considerations. I think we talked about the pain threshold, that maybe some on the spectrum don't feel pain like neurotypical patients do. So they could be laughing at you with appendicitis. You touch their stomach, they laugh. They could be running out of an emergency room with a fracture in their leg. They could be smacking you in the face with a broken arm. You have to regroup. In our usual world, we're used to going clinically, powers of observation. They came in and said they fell, but you know, the kid's walking. I just don't think there's a problem. Talk to the parents. Maybe the only indicator is that change in behavior. Maybe you're going to have to do a little bit extra, whereas people are going to think you're crazy that you're getting an x-ray. But you can't blame it all on the autism. You just can't. Seizures. If someone comes in and all of a sudden there's a sleep disturbance, there's a propensity for many on the spectrum to have a seizure disorder. Could they be having a seizure at night? If someone found their adult child or their younger child very lethargic and just think, I can't explain it. They were just very lethargic for an hour or so. He was in the other room playing and didn't have a fever and then just sort of bounced back. Are they post-ictal? We as physicians know post-ictal means you're sleepy, you just had a seizure. Keep that on your radar. The dentist. Often this falls through the cracks. Think about it. They can't get in our office to have us look in a sore throat. Now imagine a dental visit, sitting there and having someone probe at your teeth. There may be sort of a delay in getting preventive dental care. So if all of a sudden there's a food aversion and there hadn't been a food aversion before, if all of a sudden they're spitting their food out, do they have cavities? Is something else going on? Don't blame it all on the autism. Don't say he just doesn't like food because he's autistic. Check in. Is this a baseline or is this new? So now we come to anticipatory guidance, and I put that picture up there because I look at this as just sprinkling seeds. Like I said, you're not going to definitively predict what's going to come, but you can sprinkle seeds of what may and give some advice. Let's start with safety. So I was alluding to the fact before that, when I do a 6-month-old checkup, I say to the parents, listen, by the 9-month checkup, they're going to be crawling, they're going to have this pincer grasp, they can pick things up, every stink bug will be going in their mouth. Think about baby proofing. How many internists are talking about safety issues with a 28-year-old or their parent who's in the room or their friend who's in the room with them? What are those safety issues? Wandering. So we're still gathering statistics on how prevalent this is. So far, it's looking like at least half will wander at some point, but here's the kicker. We're used to our toddlers running off. You might not wander for the first time till you're 22. So it's something to educate parents about. There was a wonderful study that talked about the fact that 96% of parents had a feeling that this was going to happen or had happened to them. 14% of them had heard from their physician about it. Just talk about it. And what do? What's practical? Well, if they're going off to a camp, for the younger kids, there's some really neat tattoos on the internet that don't wear off in the water that actually have all your identifying information, phone numbers, your name, says that you have autism. Boom. Tattoos are the thing. They'll fit right in. There are tags that can be sewn into clothing when you're going away. Project Lifesaver is unbelievable. Project Lifesaver is spreading out across our country. We have it here in Montgomery County. It is free. If you have someone in your family who has Alzheimer's, dementia, autism, and tends to wander, this has been funded such that they will come to your home. They will give you this wristband that hopefully it will be worn. It has a radio frequency in it. Their find time is 30 minutes. In a practical sense, the reason why it probably got funded, they saved thousands and thousands of dollars in mobilizing personnel. 30 minutes is not usually what you hear. And Project Lifesaver is spreading out internationally such that when you go on vacation, you can pull up Orlando and see that they have a place there and register with them while you're in Disney, right? I mean, this is an amazing piece of technology that we can just set people free with if maybe they've been nervous about going on a family vacation. The other thing about wandering I want you to think about is I want you to imagine a 28-year-old or a 35-year-old in his pajamas in the middle of the night, disheveled, wandering around a highway, who then gets combative with a police officer. Are you seeing a taser coming next? This is scary stuff. So what are some of the other things they could do? Do they have door chimes? Will it wake you though? I know in our house it wouldn't. Do you have a house alarm? Do you want to get a house alarm? Do you want to make it that the sirens blare when a door is opened at night? Because this isn't a 4-year-old wandering. This is a 28-year-old wandering, or this is someone who hasn't wandered yet. We just don't know. Swimming. Many times, patients on the spectrum are drawn to bodies of water when they wander. And we know this outcome could be horrific. I talk to people about milestones and things to do with your child, and hey, start playing Monopoly. They're ready for this at this age. Hey, they're probably ready for some swim lessons. Are you asking your 32-year-old patient if they can float in the water? Are you asking the parent that's with them if they can float in the water? Maybe that's a suggestion to make. And these are suggestions. These are not with judgment or you missed it or you didn't do it. And I think if we deliver it that way, we're working together. First responder alerts. So A siren comes to your house, there's a fire. Do you really think they're gonna go when they're called to that rescuer? Maybe this needs to be in the front door, maybe it needs to be in a bedroom window, but a quick alert, those 4 little blurbs right there are perfect for them to know. They might hide from you. Now, we're used to maybe a 4-year-old hiding, but again, is a 35-year-old gonna hide? Yes, a lot of these behaviors are not going to extinguish. Menstruation, that's coming. There's no doubt about it. We in our office start talking just about puberty at 8 and 9 years of age. Hey, is this gonna happen? It's starting to come. We need to start that conversation and have them do something about it. And I've been looking at creative solutions parents have come up with. And one I found, an incredible open family. Their older daughter, who's neurotypical, from the age her sister was 8, her sister has autism, brought her with her for the entire process of menstruation every month. And they talked about it. There was another mother who simply just did a series of pictures talking about it. If this happens, then this happens. When this happens, this happens. You need to prepare. Change is the enemy. You've got years to prepare if we talk to them about it. Behavior, hugely confusing for parents, right? Is this behavior the autism? Or are they being a brat? Kids are still kids, right? And how much of this behavior are we actually reinforcing? Again, my stories illustrate it. I had a mom who said to me when I was going through just these activities of daily living, can your son dress himself? He was 8 years old. Usually by about age 4 or 5, you're dressing yourself. Can your son dress himself? She said, no, that triggers a huge tantrum. I still get up, I still dress him. It's exhausting every morning. She came back to me months later and said, you know, I checked in with the school. He's been dressing himself there, getting his coat on fine. She was reinforcing maladaptive behavior. So again, it's a suggestion just to say, what are the challenging behaviors you have, and have you revisited them? Are they really still there? Or are you just so used to doing it that you don't know that if you stop, it's actually going to be okay? Again, a suggestion. Coexisting or evolving diagnoses. We need to think about this as physicians. If those pencils bother you, you're welcome for the diagnosis. But in the world of autism, imagine you guys can line them up and take the stress off, right? But what if their world's always like that and it bothers them and they can't line the pencils up? So internists, you might meet someone for the first time and say, this guy's just really anxiety ridden. Yes, an adult on the spectrum might present with anxiety and OCD. It goes along with it. Even in the younger kids, we see it. I can't prove this, but it's a thought I give out to physicians. If we took the edge off of that, could other things get better? It's a conversation. Do you want to do a trial of medication? Talk about it, suggest it. The seizures we talked about. Complementary alternative medicine. I find what works best is to talk about it with parents. One thing I do is choose a couple of simple guidelines. I tell them, if you find something that cures all and has no side effects, it can't be real, because we don't have any medicines on the face of this earth that do that, including Tylenol. So I want you to pause, and I want you to bring me that. The other thing I do is I tell them that natural doesn't equal safe. Natural sounds good. It sounds crunchy granola. Cool, I'm going the natural way. But you know what? My mom's a natural person. And actually, it's sort of bummed I became a physician. But I grew up on this stuff, complementary alternative medicine. And I'm only kidding. She's very proud. But one night, Christmas Eve, I will never forget it. My mother called me upstairs and said, Faith Ellen, I have this rash all over my body. And she had petechiae all over her body. And the doctors in the room know that means you could have some trouble with clotting your blood. It could be very dangerous. So we looked at each other and we said, off to the ER we go. So we go to the ER, we get a blood count. Blood count's fine, there's nothing going on. And I looked at her and said, what's your latest potion you're drinking? And she said, oh, I take ginger, the kind you cook with, and I dissolve it in warm water. It's very good for your digestion, you know. So I went to this website that I'm addicted to and I give to parents, and I looked up ginger, and it has anticoagulating properties. It interferes with your blood clotting. That's a huge thing to know, I guess, before surgery or something, right? This website is something that is absolutely delightful, and I will, at the end, we'll give you contact information if you want it for yourself. I've learned a lot about complementary alternative medicine, specifically herbs and supplements through it. And I've given it to parents. I've sort of, a lot of times if I give it to them and they research it, we've actually figured the answer out without an article even coming back to me about what they were thinking about. But what this is at the NIH, they have a list of verbs, it's alphabetized, they have a list of supplements, and they took all the studies done from all around the world, and they reviewed them, and then they graded these things. And they said, is it safe? Is it effective? They graded how effective and safe it is. Is it up and coming? What's it good for? It's fantastic. It's objective evidence. It's not judgmental. And that's what I think the parents like and I like too. This is data gathering. It's kooky to try that stuff. This is what we know about it right now. We're getting it. And when I tell parents, the reason the NIH is doing that is because we don't know enough about it and we need to learn too, and they're helping educate us, the credibility is automatically there. If they're doing something that's not harmful and is possibly effective and they can afford it, that's great. Yoga, therapeutic horseback riding, fantastic. I love hearing about it. Teens and young adults. This is the place where I start to do my transition to talk to the internal medicine doctors in here and the family practice doctors, and just think to yourself that stadium's just spilling over with young adults. The doors are going to open and there's 3 doctors' offices on the outside and they all need medical help. Are you ready? They're not your neurotypical patients. What can we do for them? Let's check in with them. How are you doing socially? How are your life skills? What happens when you're with your peers in high school? What happens at your job if you have one? How are you doing reading facial expressions? There's a mom whose son practiced with pictures to understand facial expressions and how to respond. And he memorized that when people laugh, you laugh. That's called joking around. So whether you get it or not, to fit in when they laugh, you laugh. So they were at a function where kids were making fun of him, and he kept laughing with them. And that irritated them, but that's all he knew. And he ended up getting beaten up. Oh. So check in with that. There's ways to help them learn, but also have discussions. Another great website, dotolearn.com, I love it. It has these skills groups where you work on videos and pictures of what expressions mean and how we respond to them. It's not perfect, but it's a suggestion to make. How are they doing in real life? We spend a lot of money trying to get these kids to talk. Can they buy a Coke? Can they ride a bus? I have a dad who puts a little earpiece, a little Bluetooth in his daughter's ear in the morning. She's in high school. He can see her from his window. She wants that independence, and he talks her through it. And guess what? This is the day and age where you can talk on a Bluetooth and not look crazy. We see everybody doing that, talking to themselves all the time. So there are some harnesses of technology we can do or we can suggest. Can you sit out in the car and talk them through buying a Coke? That cashier's used to seeing people talk on their cell phones while they're buying a Coke from them. Maybe we could start working on these things. Strengths, interests, and abilities. I tell my population of parents, start noting what they like to do and what they're interested in. We can also regroup with the adult population and ask, what do you like to do? What are you interested in? Why? Because maybe we could find you a job. Studies have shown working improves behavior and social skills. There is less maladaptive behavior when patients on the spectrum work. A special skill example. There's a dad in Canada who noted his son was amazing with Legos. His spatial abilities are just out of the box. That's a horrible joke. But anyway, so he harnessed that as his son got older. His son has a website where people call him when they get the torturous gifts that my kids used to get at Christmas that need to be put together. And he comes to the house and he assembles them for you. Or anything you've ordered that needs assembly. He charges $15 to do it. I would give him $100 to put together the crap that I've gotten for Christmas. So that's an amazing thing. That came from an observation. Why are they good employees? Change is the enemy in the world of autism. Do you think they want to call in sick? It's a break in the routine. Do you think they really get how to lie to you about something? Employee turnover. They don't want to leave you. They want to work for you for the next 45 years. It's a change. They're great people to hire, and the job opportunities are out there. I can't say I'll find a job for my patients, but I'll plant this seed. Go explore. These people are doing it. Walgreens, Home Depot, CVS, Giant Food. There's a chocolate shop in the Kentlands who has a little chocolate factory, and they have patients on the spectrum working in there. Think about us doing some things that they couldn't pay us enough to do over and over and over again. Maybe rolling a piece of chocolate. It's pleasurable to many on the spectrum. This is a win-win for everybody. Medical schools, I talked about the medical students interviewing patients on the spectrum. Those patients got paid. They could earn a living. I want to talk to the medical schools. But what kind of environment? What do I do? What if it's not obvious to me? What if they're not a Lego builder? Again, another website, fantastic, where an adult patient or you can put in for your child characteristics of them, and it'll sort of help guide you. This would be the type of job you might want to look for. This is what would work with your child. It actually even goes through how to interview. It's great. I mean, think about what I talked about when I said leave your ego at the door. If you're interviewing someone for a job and they're not looking at you, or they're telling you your cologne's horrible, right? So this is some preparation we have to do. Can they go to college? Because colleges are thinking about them. There's a lot on the spectrum that are excellent in computers and can go do computer science. I'm not saying it's easy. There's probably going to be a lot of work with living in a dorm, but maybe they could commute. Maybe they could go to the community college. Southern Methodist University has an official gamers and app design program. There are many who would eat this up. Living life. This is something that, again, needs to be suggested without judgment or pressure. There are some autism-friendly places. I have a list of them down here. There are movie theaters here, there are movie theaters in Virginia that will have sort of low sensory nights where they might leave the lights on, turn the volume down a bit. Everybody comes and no one cares if anyone screams because everybody gets each other, right? There are certain restaurants that mothers can talk to mothers and know that restaurant will work with you. Oh yeah, I've gone there so many times. That staff knows exactly what to do. We sit at the same table. They're good about it. They love it. You're educating the public about this, right? There are places to go for haircuts that will work with you. Suggest they talk, they network, they talk to other people. There are things out there that you can just say, have you thought of? Because a lot of these families are hunkered down. They maybe haven't thought to go because they didn't think there was the autism-friendly world out there. But there are also some autism non-friendly worlds you might suggest they go into. And I don't know whether this will never work for anyone else, but my Michael story is that Michael's parents love to travel and Michael does not. And they took him on his first airplane trip. And he screamed the entire time. And Beth stood up and said to everyone on the plane, he has autism, he can't help it. Order as much alcohol as you want, it's on me. They got an education, they got drinks, they continued to take that kid on an airplane. Do you know he now, when I go over his house, pulls up his computer and says to me, car will come, Dulles Airport. He goes there, he shows me on the map where they're going, and he packs his bags and he puts them at the front door. So again, could some behaviors maybe be extinguishing if we do it over and over again? I don't know. Another great example is that we need to step back and realize that there could be a different timeline. Again, I want this formally studied as far as timelines go and persistence and whether we should do it or not. Typically, a child learns to ride a bike at age 5 or 6. Beth and her family tried every year, every summer, for 9 years. At age 14, Michael came to my house with his knees bleeding because he learned to ride a bike this past summer. I actually said to them, you guys are crazy, but crazy good. Who tries for 9 years? So maybe he's not going to, or he can't. Is he's not doing it now or yet? Just a seed to plant, a story to tell. Concluding thoughts. There's our connecting us all together. If you have thoughts or questions or you want to get some of those websites that I put up there. We need to pass the torch. We cannot as physicians pass it alone. We as physicians and parents need to come together and pass this torch together. We need to cross-train each other. I think autism is something that many physicians see in a chart and they might dread for all the reasons we talked about. But autism is a gift to us as doctors. And this is summarized up by 2 medical students who had 30 minutes of interaction interviewing a patient on the spectrum. They asked the medical students afterwards, what'd you learn about that? And one said, I learned to take people as individuals instead of treating them as a representation of a disorder. And that was enlightening. So as a doctor, we pause when we see someone who has autism and we're reminded, behind that door isn't a hypertensive patient. Behind that one is not a diabetic patient. Behind those doors are individuals with individual struggles and worlds. They remind us of that. That's a gift. The other quote is, I appreciated the perspective that the patients gave on their disorder. It will help me with future encounters with patients with disabilities. I'll go beyond patients with disabilities. our reach as physicians, it's extending our quality visits. Those switches that we need to flip, as I call it, those adjustments that we need to make, we can do them for someone with Alzheimer's. We can do someone who has dementia. We can do them with someone who has a language barrier. They just don't speak English. We can just do them with someone who's absolutely just terrified sitting in our office. It applies to everyone. Hence why I'm challenged. Why should this be in the medical school curriculum? We have so much to teach these kids. Yeah, but that applies to everybody. We learn through patients with autism to pause, to step out of our box, to take what we're used to, our order, make an adjustment, and the look you get from a parent, the gratitude you get from a patient, the difference, the huge difference you've made is a gift that I can't even explain the feeling that comes to you as a physician. You just have to feel it. But you know what? That reminds us why we became doctors. We want that. We don't get it every day. Autism gives it to us. Autism just makes us better. Thank you.